I'm sorry that I do not have the dulcet Spanish tones that I've grown used to listening to the last 2 days. So I'd like to start by acknowledging that Aboriginal people have had an unbroken and ongoing connection with the land and the harbour that we now call Sydney. And I want to remind us that that the land that we're meeting on today is the home of the Gadigal people of the Eora Nation. And today on National Sorry Day, I wish to pay my respects to elders past and present, any who are here with us today, and add my voice to those who say sorry. Now, I'm also aware that today I'm preaching to the choir. I have gathered around me today a group of people who are really interested in end-of-life care. And what I'd like to say to them, to all of the doers, is thank you for those who provide care every day, and thank you for taking time out to come in to this session. And to Professor Gomez-Batiste, I'm going to attempt this. Bienvenido a Nueva Gales del Sur, or Benvingut a Nova Gales del Sud. So that means welcome to New South Wales. At afternoon tea, these windows will be opened and you'll be able to see the Mint, which is the oldest building constructed in mainland Australia. But for the Spanish, it's going to look pretty ridiculously young. Professor Gomez-Batiste was comparing Spain and Australia, and he's correct. New South Wales has the same population as Catalonia, but we are 1.5 times the size of all of Spain. So we're probably a little bit, parts of us are probably more like Extremadura, with the kind of very disparate population. But we also have 264 public hospitals with universal health coverage, but there is the allowance for a private option as well. But there is a thing that which joins both Spain and Australia. Every single Spanish person, every single Australian person, whether they're from Catalonia or New South Wales, we are all eventually going to die. It is going to catch up with every one of us. And Professor Gomez-Batiste has been sharing with you slides of all of his incredible publications in peer-reviewed journals, and I don't have publications in all of those peer-reviewed journals. I have holiday photographs. So I have holiday photographs and family photos. So what I'd like to share with you is a picture from Latvia in 1993. And they'd clearly grasped the concept of tourist information, but they hadn't fully implemented it. So when you went to look for tourist information, there wasn't a lot there. And until recently in New South Wales, if you wanted to find out what the experience of dying was for people in our public hospital system, there wasn't a lot of information there. We could go to the Bureau of Births, Deaths and Marriages, or as we call it, Hatch, Match and Dispatch. Or, you could try and seek out and audit local medical records, but we didn't have an overview. But that's all changed. A large body of work has been done. And we know that about 50% of people die in acute care facilities, and that tallies up to 25,000 people every year. And we know that those patients experience, on average, at least 3 admissions of at least 10 days each in the 12 months prior to death. So people are spending at least a month of the last year of their life in hospitals, and that's staggered very much towards the end of that year. And similarly to your figures, only about 30% of deaths are referred to palliative care services, but the ones who are referred tend to be cancer patients. So there's very strongly a pro-cancer bias in the way we deliver our services. We also know through our incident information management system and through root cause analyses, which are performed when there's a serious incident in our hospital system, that our clinicians sometimes struggle to recognise when patients are at risk of dying, to develop appropriate treatment plans, and communicate with patients and carers. We also know from our rapid response teams that we still have rapid response calls for patients. 30% of all rapid response calls are for patients who are actually deteriorating, and the first sign we're seeing that they're deteriorating is changes in their physiological parameters, so their pulse, their respiratory rate, that kind of thing, their blood pressure. And if you audit the documentation, it rarely shows that patients and carers have been consulted about where they would like to be and their preferred place of care. In 2012, the CEC, as part of the Quality Systems Assessment, looked at end-of-life care, and staff actually reported that the challenges they struggle most with are about initiating conversations with patients and carers, struggling to recognise when patients are starting to die, and poor communication between staff and patients. And we didn't have a standardised approach in the last days of life. So I want to ask a straw poll. I want to ask you a question. I want you to think back to the last patient that you cared for at the end of their life. How well did the care they received meet their needs? All of those components of comprehensive care that Professor Gomez-Batiste outlined, did we deliver all of those? How well did we do? Like the success baby, can you say, yes, we nailed it? Or is it more the case, and this is the most fun Google search you will ever do, nailed it? You know, did you kind of not really get there? I love the Cookie Monster cupcakes that look like they've been exposed to radiation. Because end-of-life care in our facilities is incredibly variable. And some people might say, oh, it's not a problem here. We do it really well. Because we think back to the person where it did go really well. We think back to the family where it all went to plan. But can you really say in your heart that it's safe to die in your facilities? On weekends, out of business hours, when X is rostered on, when Y is not rostered on? You know, so often, individuals within wards are making a really big difference to patients, but when they're not there, it can cause serious issues. And I think it's fair to say that some patients have the Rolls-Royce experience. I really do think some of the time we deliver world-class, beautiful care. But unfortunately, I think sometimes we have burning car wrecks occasionally as well. And the goal is to actually ensure that everybody gets a reasonably good experience. And from a quality and safety perspective, the CEC is the peak kind of state quality and safety body. Our goal is to minimise harm and increase reliability, to make sure that none of the things that should not happen to people happen to them, but also to make sure that all of the things that should happen to people do happen to them. And there are challenges with this. Professor Gomez-Batiste has been talking about the differences between cancer and non-cancer patients. And as the chap says, do you have anything that stops the ageing process? The Wizard of Id responds, sure, what kind of disease would you like? And at the moment in New South Wales, I think it's fair to say that if you have cancer, chances are you will have a better experience of care than if you don't have cancer. Again, a picture of the Mint building just behind us. I was reading about the Mint on the website over this week, and I discovered that the Mint was built after the gold rushes so that we could actually mint coins here in New South Wales. And of course in Sydney, we have a significant rivalry with Melbourne. Adelaide thinks it has a rivalry with Sydney and Melbourne, but we don't think it counts. And after the Mint was actually built, there were complaints from Melbourne and Adelaide that the quality of the sovereigns and half-sovereigns that we were making here was suboptimal, and they actually put out rumours that really what we were doing was inappropriate. And when I think back to how our federation came together, Melbourne and Sydney so distrusted each other that we had to build a separate capital in another area, far from both of them, because the two couldn't get on. And so that brings me to the next challenge. And the best way I could describe this was a holiday in Japan, watching sumo wrestlers. The state and the federal government, you know, when I look at your picture of integrated care across the whole dimension, from the point in time when people first need assistance to the point in time when they die and after, I'm so jealous. Because in New South Wales, we have funding for the acute hospital system through one system, and then we have federal funding for health and ageing, which covers primary care and aged care facilities in another system. And I think there's always tensions between funding opportunities, but also we have separate accreditation systems for both. There are very different drivers for how the services are delivered. And I think that poses a significant problem for us. And yesterday we were having a discussion with Professor Gomez-Batiste about uncertainty and clinicians making decisions in the context of uncertainty. Because deep down, we don't like to be uncertain. And it's much easier if we have a sense of exactly what's happening. And one of the problems we've identified with people actually leaving discussions too late, and often until the patient is not actually able to speak for themselves, is because as clinicians, we don't like to actually talk about it until we know it's happening. You know, we need to be certain. And that's a really difficult space to be. And I think, now this is my husband with my niece, I think we have things to learn from our obstetrics colleagues who actually deal with uncertainty all the time. And they don't talk to patients and families about, on your due date, you will come into hospital and you will deliver. Because I know that most of the time it doesn't happen. Was anybody here born on the day they were due? I was 3 weeks late, and I've been 3 weeks late ever since. But we have a lot to learn about giving patients and families an understanding of these are the changes that you will see as time is getting shorter. These are the things that you can expect. When you see this, it might mean. In the same way that we teach people that when you start having contractions or your waters break, you go to the hospital. And people deal with that very comfortably in the obstetric setting. And perhaps we have something to learn from that. The other reference to baby boomers, and this is my nephew who is now 15 and would be mortified if he knew this picture was going live on the internet. I did actually tell him and watched his jaw drop. The baby boomer generation, which is rising to the forefront now, is going to demand the same flexibility that they demanded for birthing services. So the ability to have water births, home births, to be supported in a natural birthing centre as opposed to in a hospital bed in stirrups, all of that kind of process is now moving into the domain of end-of-life care. And their expectations of what we need to provide are going to have a big impact. So what can we do about this? Well, the first thing is we don't want to do something superficial that doesn't actually change anything. And the best example I could find of this was this, I don't even know what to call it, tool that I found on the internet, the Abhancer, which clearly does not actually change anything. And so if we're going to work at addressing this, we need to do more than just superficial changes or renaming things. And we don't want to do it alone. This is a kookaburra, one of our standard local birds. We don't want to do it alone. We want to do it working together, okay? And the best example I could come to explain what New South Wales is doing to address end-of-life care is actually to point out, at the Clinical Excellence Commission, we have a group of I was going to say women, but actually there are some gentlemen as well who are involved in knitting squares that go to be sewn together to form blankets. And the process is called Wrap with Love, and it's a charity process, and they send the blankets to Africa. And when I think about what is happening across New South Wales, I actually think of the Wrap with Love blankets because they're individual little bodies of work. So all of the squares are knitted by different people and crocheted by different people. But in the end, when you join them all up, they actually form a comprehensive cover that's trying to actually, cover the whole bed or cover the whole person. And so there's a whole lot of different bodies of work that are happening. And in the bigger picture, they do actually come together. They knit together to form a single body of work. Now, I appreciate that in the LHDs, when you receive one of 7 different documents about end of life, you think, who are these people? Do they talk to each other? And the thing, I suppose, the most important thing I would like to communicate to you today is, yes, we actually do. And before anything goes out, in fact, all of the other key bodies have actually reviewed it, commented, and we've all worked together. And we actually do have a unifying grand plan, which I'll share with you in a moment. But this is the best picture I could come up with of, in fact, behind the scenes, we're all holding hands and singing together. I wanted to take photographs of us skipping, but we didn't quite have the chance. It may not appear to the outside world that these documents are actually working in unison, but they're all covering different patches. So each group, each organisation is working on their square, but they do actually stitch together to try and form a comprehensive package. And what I'd like to share with you now are some of the different squares that form that overall quilt. And as I do so, I'd like to introduce some of the people who actually do some of this work. So from the ACI, from the Palliative Care Network, can I please introduce Heather Davy? Okay, welcome. And it's always awkward when you speak to someone else's slides, but are people familiar with the Palliative Care Blueprint? So the Palliative and End-of-Life Care Blueprint from the Agency for Clinical Innovation. If you go online to the ACI website, you can actually see some really comprehensive resources that have been developed for the palliative and end-of-life care network. And large bodies of work, so 2 of those reports in that picture of 7 are about the diagnostic report to inform the model of palliative and end-of-life care service provision and the framework for statewide model for palliative and end-of-life care provision. There's also been a big body of work about the fact of death analysis. And as Professor Gomez-Batiste was talking about, we've done a lot of work now on mortality, and I think the next step is to start to look at prevalence in our facilities. And the Healthcare Roundtable has started doing that body of work. And Colin Begg, where is Colin? Here we have Colin up the back. Colin is one of our consumers who's in the video, so you can see him starring online, and you'll see him on the panel this afternoon. But there's a whole series of videos that cover different components of the blueprint that you can access directly. And then the New South Wales Ambulance Service. Michelle, where's Michelle? Here we go, Michelle Shield, welcome. So Michelle is the manager of the low acuity care section of New South Wales Ambulance. And you might not think that ambulance has a lot to do with end-of-life care, but in fact, when you look at the usage of New South Wales ambulance services by age group, you'll see that it's very strongly staggered towards the higher end of the curve. And historically, if you've had trouble, all you could do was call 000, and the paramedics had limited choices about what they could actually do to support you. And basically, if you called dispatch, then you were sent an ambulance and you were taken to hospital, to the emergency department, which on a bad day might look like this. And that's clearly suboptimal for end-of-life patients. So what are we doing for palliative care patients in the end-of-life space? The first step is supporting the paramedics to provide appropriate care to those patients. And so there's currently a body of work about palliative care physicians actually facilitating training for paramedic educators. And palliative and end-of-life care is one of the scheduled training themes for the broad group of paramedics across the state. In a moment, I'll talk about the verification of death process, which has been addressed by the Ministry of Health to support this. And then development of resources to support paramedics when they're working out in our homes and on the streets. And establishing a single point access for email portal for paramedics. The goals of all of this are to maximise comfort for the patient, maintaining dignity and ensuring adequate analgesia, and controlling other symptoms such as nausea or agitation in order to support the quality of life of the patient by alleviating fear and anxiety for both patient and family that may be associated with death and dying. And then supporting patients with palliative or life-limiting illnesses through authorised palliative care plans. Are people aware that you can actually register a palliative care plan for a patient so that if an ambulance is called for them, the paramedics are supported and have clear guidelines and instructions about what they can do that are outside their normal protocols to support this patient? And that form is in the process of becoming a statewide form, so you'll be able to access it locally very easily. And it fits really well within the principles that have been highlighted in the blueprint for palliative care. Now, I mentioned the verification of death process. And as a clinician, I often struggled with patients who had gone home to die, were being supported to die at home, but if their GP wasn't available at the point in time they died, then the paramedics would be called. They had to then call the police, and depending on the seniority of the police officer, you could end up with blue and white tape around the house because someone spotted a bottle of morphine and, you know, a serious investigation. And so now, because of the work the Ministry of Health have done, paramedics are able, and also senior nurses, are able to actually verify that a patient has died so that the funeral parlour can come and collect them, and then the GP can actually do the death certificate in a timely manner, so that we don't have to wait on the availability of the GP to be able to transport a patient and support a family better. And for me, that's a really big improvement, which is going to help patients and families. And then the New South Wales Ministry of Health, another body of work, another patch in the quilt. So the New South Wales Ministry of Health has done a lot of work in the advanced care planning space and improving planning for end-of-life care. And so some of the goals are to normalise advanced care planning to improve end-of-life care, integrating patients' wishes into any advanced care planning and end-of-life decisions about them, so we don't wait until the patient is clearly actively dying and can't speak for themselves before we mention the D word. Planning is clearly the key, and working together is essential for successful implementation. And there's a number of resources, and there is a fantastic website now about advanced care planning, which actually provides legal support and clear information for clinicians as well as for family members and patients so that they can utilise this. And then end-of-life decisions. There's a further resource about the law, particularly about the law and clinical practice, and it's been endorsed by the AMA, ASMOF, the New South Wales Nurses and Midwives Association, and it addresses a series of issues that people struggle with: substitute decision-making, advanced care plans, directives, and most importantly, refusal of life-sustaining treatment. I still know a number of clinicians who believe that it is not a patient's right to refuse life-sustaining treatment. And then further resources about dignity, respect and choice, advanced care planning for end of life for people with mental illness, a comprehensive guide that covers the incredible complexities where you have a patient with a mental health issue so that they can be appropriately supported. And it's really helpful for clinicians who are not familiar with caring for patients with mental health issues. And then there's an introductory guide which is also translated into 11 community languages, and it supports people with mental illness, their families and their carers. A body of work, and here's where the acronyms kick in: SHAPE conversations. So supporting health professionals in advanced care planning and end-of-life conversations. And this is an education framework which has been developed through an expert panel with broad consultation. There is an e-learning component, but it recognises the fact that e-learning is not the answer to learning how to have these difficult conversations. And so there's an advanced skills workshop designed to be run locally for health professionals who may be required to have end-of-life conversations with patients and their carers. And part of this body of work is actually identifying mentors within health facilities who are good at these conversations, who can show junior staff how to do this well. And then I wanted to flag the body of work done by the Integrated Care Branch at the Ministry of Health, which has oversight of the New South Wales Government plan to increase access to palliative care, which was again one of those documents, one of those 7 documents. It's convened the Palliative Care Advisory Group. It's supported funding for PEACH packages, which are like EACH packages, but they're for palliative care patients to support them at home in the last few weeks of their lives. They've recently set up the Health Direct telephone support for palliative care patients, and they've also put out tenders in their flexible funding pool to address gaps in clinical service delivery. And then the last thing I wanted to comment on was also e-health. Someone has mentioned the issues of the electronic health record and how we can appropriately support people through that journey. And the first body of work that they've been working with the ministry on has been about electronic documentation of end-of-life decisions and medical orders. But they're just about to start a body of work looking at the EMR for palliative care, actually recognising that palliative care patients may be in hospital, they may be in the outpatient clinic, they may be in the oncology clinic, they may be in their homes, or they may be in residential aged care facilities. So across the spectrum, wherever the patient is, actually ensuring that that information is available to all who need it. And the last group I wanted to talk about was the end-of-life program. So Bernie King, where is Bernie? Bernie's hiding behind the pillar. That's Bernadette King, who's the clinical lead or the program lead for the end-of-life program at the CEC. And for me, it's really exciting that the Clinical Excellence Commission is the peak quality and safety body in New South Wales Health. And it's really exciting to me that they have recognised that end-of-life care is actually a quality and safety issue, and that patients at the end of life are just as deserving of high quality and safe care. And so there's a number of different opportunities that we've been working on. So the Amber Care Bundle is a clinical care bundle which was developed in the United Kingdom for patients whose recovery is uncertain. So when we say that people struggle when they're not certain exactly what's going to happen to the patient, this is supporting people to actually acknowledge the uncertainty and have a discussion. If this happens, this is what we'll do. You know, we're going to give this treatment. If it doesn't work, then this is what we're going to do. And actually give people a sense of what the options are. Prompting multidisciplinary decision-making and key conversations with patients and carers, involving the patients before they're unresponsive. The Phase 1 pilot has been completed and it's available for further rollout and ongoing qualitative evaluation. We've been utilising the SPIC tool and encouraging people to use the SPIC tool, but having heard about NECPAL, I have a feeling that you guys will be hearing a bit more about NECPAL in the not too distant future. So SPIC stands for the Supportive and Palliative Care Indicators tool, which is a really simple one-page format that prompts people to contemplate, particularly in the non-malignant diseases, what are appropriate indicators to prompt referral to palliative care. And then the Last Days of Life Toolkit. And interestingly, it's called the Last Days of Life Toolkit because it is a toolkit. You can choose the bits that you need. But also, Last Days of Life was the only phrase that meant the same thing to patients and families as it did to clinicians. So the Last Days of Life Toolkit has been developed by a team of 71 specialist and generalist clinicians and consumers across New South Wales. And I'd like to say thank you to those of you who are here in the room today. And it's been developed by specialist clinicians for non-palliative care inpatient settings in New South Wales, and that includes residential aged care facilities should they wish to use them. And there are supporting resources and educational strategies alongside each of the tools. And it covers tools to prompt and support communication, both verbal and written. There is a comfort observation and symptom assessment chart for the dying patient. So instead of actually monitoring people's vital signs, we're actually monitoring them. And we're also monitoring their families. There are guidelines for standardised medications to be tailored to that individual patient's requirement. And there's also a transition to die at home package. So all of the things that the palliative care CNS does when someone calls and requests a last minute transfer home, it's all supported so that generalists can also make sure they've covered all of the important issues. And particularly linking in with the ambulance protocol 1s or palliative care plans. The last thing that we've been involved with is the Death Review database, which is a database which just supports the inpatient death screening tool, which is now being used in kind of 17 of the LHDs. It started at the beginning of last year, and we've already had 21,000 deaths screened. And the focus is shifting just from assessing whether a death was preventable to actually looking at the experience of dying, whether appropriate communication has been had with patient and family, and documenting the comfort of the patient as well. So looking at the experience of dying, not just whether it was a preventable death. But all of these different patches form a larger quilt. But I still think there are a whole lot of opportunities for us. And when I listen to Professor Gomez-Batiste, I think about how many things we could do. And then I try and console myself. We're young, we're babies, compared to a 25-year comprehensive plan that's been in place for a really long time. But we do have opportunities to identify and support those with chronic non-malignant conditions, to identify those who are at risk of dying. I do think we've done a body of work on mortality, but we have an opportunity to do a body of work on prevalence, and that has started at the Healthcare Roundtable. We have an opportunity to have earlier and better conversations and actually own uncertainty. We have an opportunity to better support those in residential aged care facility settings and support them in their accreditation and their funding drivers and address the issues which drive the care that they deliver. I think we have opportunities to improve how we document and how we collect our data. When I look back at 25 years worth of data and the ability to pull that all together, I'm just in awe. But I also think we can assess things from the outside, but the real people who can speak to this are the people who've experienced it. And in the UK, they've done a body of work called called Voices, which is actually kind of like a patient satisfaction questionnaire, but it's actually for the bereaved carers of patients who've died in the health service. And I think we have an opportunity in New South Wales to explore how we actually assess the care we've provided and how we actually learn from that care by actually speaking to those who've lived through it. So I'd like to finish with a very big thank you. I'd like to thank all of those who organised today. And in particular, sitting quietly up the back is Donna Lloyd, who has done an amazing job from the CEC, and she's now really embarrassed that I've pointed her out. I'd like to thank Donna for doing an incredible job. Donna works 2 days a week and has pulled this together with the support of Bernie and Maria Gomez and Jen Gillett and Heather Davy, but we've had a large body of people who've come together, but my personal thanks to Donna. I'd also like to thank all of those who attended the session this afternoon. And I'd like to thank Professor Gomez-Batiste and Professor Lynn Gillam, who you will come to see the awesomeness that is Lynn very shortly. So I think it's time for afternoon tea, so I'll leave it at that. Okay? Thank you very much.